Good evening, friends. Today I have come up with this very important topic called maternal near miss. Many places they have not yet started the audits, but there are many hospitals who have already started this kind of audits and they're finding it useful. In Manipal, we have started this some 10 years ago, and as you can see in the later part of the talk, we have improved a lot on our previous performances. It's the need of an hour. The the countries which have so-called developed countries, they have conquered in a way the maternal mortality, and they are the ones now discussing the near miss cases. So we also have to discuss side by side the maternal mortality, the near miss cases as well, so that we can totally improve simultaneously in reducing both mortality as well as near miss. So this can be a recent advanced question for you, or it can be a question even in the obstetrics for the postgraduates. It's a very, very important concept. You will have a question definitely on this. And for the private hospitals, government hospitals, private nursing homes, this is a very important exercise to be conducted every year. So you will soon realize the utility of this after the lecture. Next, 2 months later, that is the same day, today is February 11th, and April 11th is the National Safe Motherhood Day. And let's make their lives safer. Now, what is this? A big Boeing is trying to take off, and another Boeing is trying to land on the same runway. It's a sure recipe for disaster. What happens next is very, very interesting. This is not a picture. This is not a photoshopped picture. At the end of the talk, I'm going to show you the actual video. But now just watch how the disaster was averted. Oh my God, just missed. So this is a perfect sort of analogy I can give you how you can save the person who is almost dying. One of the best trainings in the world is in the aeroplane industry or in the air industry, I should say. A good friend of mine is a pilot in Lufthansa. He told me once that in the dictionary of pilots, there is nothing like accident. I was wondering, what do you mean by that? He said, before an accident happens, there would be 17 clues, 17 clues, which if you really take care of or notice, then an accident can be averted. We always think the accident is an accident. How can you prevent an accident? No, you can prevent an accident as well. Next time when you fly or before flying, just watch the pilot himself checks at least 20 points. I just took this picture, and they will check everywhere. That is the kind of safety precaution we must always observe to save the lives of our patients. 300,000 women died in 2015 as a result of pregnancy related conditions. That's really, really sad. But what is satisfying or what is gratifying is that 5 times more women knocked the door of death and they were saved. I would like to just give a prelude to the talk by quoting the maternal mortality in South India. Kerala, of course, is the best state, not only in South India, but also in the country. Their target is 30 by 2030, something like that. Tamil Nadu is definitely next, and Telangana is 81, Andhra Pradesh is 74, better. Karnataka is unfortunately little more only. But nationally, if you look at, it is still somewhere between 120 to 300. Some states it is still 300. Some states have come down to 120. Udupi is the district where Manipal is situated. And I'm very proud and happy to say this is the statistics of something like 2018, 17, 18. When I first did this lecture, I had quoted this. It is 1.3 per 100,000, so low. I will tell you how we could achieve that. Of course, the subsequent year it was 24, and later the recent one I don't know. KMC Manipal, what is the maternal mortality? It was 0 among booked cases. Of course, we had 9 maternal deaths, but all of them were referred from outside, we being the tertiary care hospital. And usually patients are referred in the late situations, or maybe patients themselves come very late. And as you know, if a patient dies within 1 hour after entering the hospital, you cannot blame that hospital. Also, if the patient doesn't belong to the district, the maternal mortality is counted under the district which referred to it. So that is the situation. This is possible by actually regularly conducting near miss audit. So that's why the talk I thought is very relevant, and I should talk about this today. Maternal near miss concept and audit need of the hour. Near miss maternal morbidity. What is this? In 2007, WHO established a technical working group comprising of obstetricians, midwives, epidemiologists, and public health care professionals to develop a standard definition and uniform identification criteria for maternal near miss cases. Otherwise, what happens all over the world, there are different types of facilities, different types of statistics, and there will be a chaos. Maternal near miss is a condition of a woman who almost died during pregnancy, childbirth, or 42 days postpartum. Can't you see this? The second clause is almost like that of a maternal mortality, that is during pregnancy, childbirth, or 42 days postpartum. The only difference is we could save her. She didn't die. That is near miss. Events, in another definition, events that would have resulted in a maternal death during pregnancy and childbirth and 42 days after that, if not for significant medical intervention. So medical intervention saved her. It's a pride for us, as well as it's a duty of every doctor. Near miss maternal morbidity is more in high income countries. That means they have conquered in a way the mortality. The morbidity is more, but mortality is less. Anyway, we can take care of the morbidity, but mortality, you can never get back the mother. And they are more than mortalities. That's okay. But mortality is irreplaceable, irrecoverable. Why we must do this near miss audit in every single hospital, small or big? Near miss and maternal mortality have similar pathology and complications of pregnancy. It's just a matter, the same pathology either kills the mother, or with a proper and timely intervention, you can save the mother. So that's why if you do the maternal mortality audit, and if you do the maternal near miss audit, it is the same pathology and it's the same complication that you will come across. So the, what do you call, the developed countries, since the mortality is very, very low, some Sweden and all will have 3, 4, something like that, they have started the near miss audit because the pathology that leads to mortality are same. By evaluating these, much can be learned about the causes and processes in place. It's not just finding out the cause. You will also have an insight or introspection into the processes in place where we missed, whether there was a delay in reporting of the patient, whether there was a delay in starting of the treatment, whether there was a delay in proper referring of the patient. So all these issues you can actually review when you do a audit. That's why it's a must. And we have been doing it in Manipal very religiously every year since so many years now. Processes in place or lack of them, that is also very important to tackle the cases. Near miss audit utility is not just, as I said, saving the patient. To determine the frequency of complications also you will know, and which are the indirect indicators of maternal death, to provide information on the quality of maternal care for life-threatening complications. Suppose your mortality is more, that means your quality of care is not so good. If your near miss cases are more, that means your quality of care is very good. To evaluate healthcare facilities and interventions that is taken, and it raises awareness, fosters changes towards improvement of maternal health care. So that is the reason we all must have not only the confidential inquiry into maternal mortality, but we must straight away start near miss audit. What is the concept and principle? The concept is it's a criterion based clinical audit. It's not simply looking for how many cases we had, complications. So there are specific criteria. Then there will be uniform type of audit and uniform type of statistics that you can get across the country and the world. What are the principles? The ease of use. Any audit that you do, the terms and conditions, what we say, or the criteria should be easily applicable to everybody. You should not have very complicated criteria. Then ordinary nurses or simple, the PGs and interns cannot do this. They can also do this audit very easily if you give clear-cut criteria. Actionable results. See, just finding out what is the cause is not enough. So whenever you learn a lesson, there should be actionable points and they should result in a positive outcome. That is also important. And the actions or interventions should be cost effective. What are the assumptions? All maternal deaths involve at least one life-threatening condition or an organ dysfunction. This is the assumption with which you go. So that means, suppose a mother is dying, that means definitely there is a one life-threatening condition or an organ dysfunction, and that was probably not looked for in the earlier or not be followed up. For example, let's say if you tackle preeclampsia, if you diagnose preeclampsia in time and manage that properly, you will not straight away land up in a situation of eclampsia, which is definitely a life-threatening condition. So that's what I mean by knowing this is very important. A substantial portion of them have severe pregnancy-related complications. It's not just life-threatening complication, which is extraneous. It is pregnancy-related. As I just now told you, it could be a severe PPH or a preeclampsia, or they receive critical intervention. So it need not be always a case of recognition, but at the intervention level, that is, they have received a critical intervention, for example, an ICU care or a transfusion. The common criteria with all this knowledge, number one is multi-system failure or severe dysfunction, which is a case of near miss. If somebody asks you, a case which had a multi-system failure or severe dysfunction, for example, respiratory dysfunction or respiratory failure, cardiac failure, renal failure. Number two, the case which needed major intervention or interventions or resuscitation, for example, intubation, transfusion, hysterectomy, the cesarean hysterectomy or emergency hysterectomy, or ICU admission. So it is number one, multi-system failure, which required a major intervention. And the patient had a serious category of disease, for example, severe hemorrhage or an eclampsia. So this forms a common sort of criteria or a broad criteria, I can say, before we go into the specific criteria. So this is almost like a political statement, major system failure. What do you mean by that? How do you define that? Major intervention. Of course, I have given examples of intubation and all that, but still, can you Transfusion, how many bottles of blood, right? So like that, we go into the small prints little later in the next subsequent slides. So the best criteria is the WHO criteria, who have thought very, very, elaborately, and they have given us beautiful criteria. So critical interventions or ICU is, if you take that as the criteria, then you will say patient was admitted to ICU, blood products were used, interventional radiology was used, maybe like UAE, uterine artery embolization in OBG, laparotomy, including hysterectomy, excludes cesarean section. Of course, cesarean section is not life-threatening, but after cesarean section, if she lands up in bleeding, and that's why you do a emergency hysterectomy, that becomes the intervention, emergency intervention. The next criteria is life-threatening condition. What do you mean by that? Under CVS, you may have had shock, cardiac arrest, use of continuous vasoactive drugs to keep up her BP, cardiopulmonary resuscitation, maybe there was an arrest and you did CPR, or severe hypoperfusion where lactate was more than 45 mg per dl, or there was severe acidosis in terms of pH being less than 7.1. So that is about life-threatening condition in CVS. Now, what do you mean by life-threatening condition in RS? Acute cyanosis, gasping, severe tachypnea, more than 40 breaths per minute, or severe bradypnea, less than 6 breaths per minute. Intubation and ventilation not related to anesthesia. Sometimes what happens after cesarean section, they won't be able to extubate her. They'll keep her for a long time. That is not the reason, but you intubated to save her life. Severe hypoxemia, oxygen saturation less than 90%, lasting for more than 60 minutes. Next, life-threatening conditions in hepatorenal system. As far as hepatic is concerned, jaundice in the presence of preeclampsia, we all know that it goes to HELP syndrome due to severe hemolysis. Severe acute hyperbilirubinemia due to any reason, maybe hepatitis itself. Renal oliguria, non-responsive to fluids or diuretics, a typical case of sepsis. Dialysis for acute renal failure. Other day I took acute kidney injury class, and there I told you that dialysis sometimes is the only solution in the last stages of kidney disease, acute kidney injury. So that comes under near miss case. Severe acute azotemia, that is creatinine more than 3.5 milligrams per dl. How fast it happens is another thing. Generally, other life-threatening conditions such as coagulation failure to form the clots, massive transfusion of blood products, more than 5 units because she has gone into DIC, severe acute thrombocytopenia, which means less than 50,000 platelets per ml, we all know that, uterine hemorrhage or infection leading to hysterectomy, both, okay? So they are the life-threatening conditions. Neurologically speaking, prolonged unconsciousness lasting for more than 12 hours or coma, including metabolic coma. Stroke or uncontrollable fit status epilepticus. It may be because of either eclampsia or because of other reasons. Total paralysis. So to summarize all that what I told in different slides, this particular slide, one slide will tell you everything. At the end of this slide, you can take a snapshot or the screenshot of this particular slide. As far as clinical criteria, shock, oliguria, unresponsive to fluids and diuretics, loss of consciousness for more than 12 hours or seizures, jaundice with preeclampsia, clotting failure, acute cyanosis or gasping, where respiratory rate can be more than 40 or less than 6, all put together in one column. Next one is lab criteria. Oxygen saturation less than 90 for more than 60 minutes, partial oxygen to FiO2 less than 200, creatinine more than 3.5, bilirubin more than 6, pH less than 7.1, lactate more than 5, platelet less than 50,000. What I told in different organ systems, everything is put in in a different bottle. The same wine is put in a different glass. So here we are dividing not organ-wise or system-wise, we are dividing according to clinical criteria, lab criteria, and finally management criteria or interventional criteria. If you had to use vasoactive drugs, if you had to do hysterectomy due to infection or bleeding, if you had to give more than 5 transfusions, if you had to do intubation, and then mechanical ventilation for more than 60 minutes, which is not related to anesthesia, if you had to do dialysis and cardiopulmonary resuscitation. So this is the final WHO criteria, which is to recognize a near miss case. So it can be uniformly applied all over the world. But it was so elaborate, it was so exhaustive. And if the PGs or any clinicians complain, sir, that is too much. Being Muralidhar, you have to simplify this for us. If you tell me like that, I have found out a just 5-factor scoring system, which has got 100% sensitivity and 93% specificity. So you don't have to remember that elaborate criteria. Of course, you have already taken a snapshot and you can always open your mobile and see what is the criteria. But these 5, without taking snapshot, it can be there in your mind. What are they? Number 1, transfusion more than 4 units of blood products. In Manipal, most of the time, every month we ask, there is a statistics, every month statistics goes on, and in that statistics, we try to filter out which are the near miss cases. And one quick criteria we take is if somebody took more than 4 units of blood, straight away she goes to near miss audit or discussion. Every 2 months we do that. ICU admission, another easy way of ticking that it's a case of near miss. Intubation, once you go to ICU, most of the time they are intubated if they want ventilation. More than 12 hours is. Then organ failure, either renal failure or liver failure or any other organ failure, automatically it's a near miss case. And unanticipated surgical intervention, hysterectomy, for example, or drainage or opening laparotomy in cases of ectopic pregnancy maybe. So this is very easy to remember, starting with the blood transfusion, which is very, very common in obstetrics. ICU admission also very easy to remember. Intubation, ICU go together, organ failure, and unanticipated surgical intervention. Now, after simplifying that such a big elaborate criteria into just 5-factor scoring system, if some PGs still complain, sir, it is too much, just tell us 2-factor scoring system. I have one more, which also has got, let us say, 100% sensitivity and 93% specificity still. And that is just 2 criteria: transfusion more than 4 units of blood products and ICU admission. Enough to say that she's a case of near miss. Because ICU admission automatically means intubation, automatically means some intervention, like in emergency intervention, like hysterectomy or draining of the pus or something like that. And inotropic drugs are usually given. So this is good. Of course, the specificity comes down to a little bit, 78%, but sensitivity is 100%. It is maintaining the sensitivity. So I hope now onwards, nobody will miss a case of near miss. Just 2 criteria, remember. Transfusion more than 4 pints, it's a case of near miss. ICU admission, it's a near miss. Thereafter, if you want, you can go into details like oxygen saturation, intubation, bilirubin, and liver enzymes, and all those things. What is a 3-step approach? In a cyclical manner, we have to find out the baseline assessment or reassessment, quick assessment, what we say, and then situation analysis. What is the situation the patient is in? And finally, what intervention was taken for improving the healthcare. So these are the 3-step approach that WHO has prescribed. In the baseline assessment, near miss criteria, based clinical audit should be done. Healthcare consumers, near miss women, providers, and managers views this. Then we have situation analysis, that means identification of opportunities and obstacles for improving care. And finally, at the implementation level, a tailored and multifaceted intervention for improving care, that is audit and feedback, engagements of opinion leaders and early adopters, development and use of local protocols, reminders and educational activities, prospective case identifications, and use of evidence-based checklists. So these are all interconnected. So this approach would definitely bring down our maternal mortality, and also we can give better health care to the mothers. So if somebody wants that whole elaborate criteria, we don't know how to do it, you can straight away go for data collection using this particular website of the WHO and click on this link. You will get whole the pro forma, and it's a big one. I'm not intending to talk elaborately on each one of them. As you can see here clearly, the questions are severe complications, potentially life-threatening. A0 means severe postpartum hemorrhage, A1 is severe eclampsia or preeclampsia, and A3 is sepsis, A4 is ruptured. Like that, you have very detailed pro forma where you have to simply tick, 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 you have to do. So it's a very beautiful pro forma. So it also includes what type of delivery happened, what is the laparotomy for ectopic pregnancy, laparotomy for ruptured uterus, everything is there. So you have to tick this so that you can analyze this nicely, especially if somebody wants to do a thesis on this. Please download this form and put it in the software, and you can easily analyze this later. Now, sample size and timelines. Minimum sample size for producing near miss and process indicators has not been established, but expected numbers of all eligible women as per criteria is 37 per 100,000, rather 1,000, and severe maternal outcomes 7.5 for 1,000 deliveries. Sample size should be calculated based on prevalence in a given center. Now, having understood this concept, criteria, and everything, let us see what are the indicators of near miss. Because when you start doing audit, you should know where do we stand. So what are the indicators? Maternal near miss ratio is one of the indicators. What is this? Number of near miss cases per 1,000 live births. Very simple ratio. That means on the numerator, you have number of near miss cases. Maybe a severe preeclampsia, maybe an ectopic pregnancy who received 4 pints of blood, maybe a case of eclampsia, maybe a case of renal failure, whatever it is. Divided by 1,000 live births will give you what is called near miss ratio. This is not much of utility. It will just tell you how many cases you had. What is more important than this is women with life-threatening conditions. This gives the sum of maternal near miss and maternal deaths, both. So this will tell you how many women had life-threatening condition. Some of them died due to it, all right, but some of them saved because of it is all right, but you will get a total picture when you add them. So WLTC means MNM plus MD. But this is very, very important. This slide is very important. Let us understand this properly. Maternal near miss mortality ratio. What does it mean? The ratio between near miss cases and deaths. How many near miss cases you had, and out of them, how many died? That is very simple mathematics. Near miss on the numerator, maternal deaths in the denominator. Higher the better. That means you had more number of near miss cases, but very few died. Suppose you had 100 near miss cases, only 10 died, the ratio is 10. Whereas if 50 died, the ratio will be 2. So higher the ratio is better. You had 100 near miss cases, 50 died, what will be the ratio? Just 2. Whereas 10 died, ratio will be 10. So low means there were more deaths. Denominator was bigger. I am giving an example here, same example I am giving. That is 100 cases of near miss, only 10 died. The ratio is 10. Whereas if 25 died, I gave 50 died, that was 2. Now it is 4, slightly looking better than that. But there should be more number of near miss cases, less number of deaths. This is a very good indicator, right? So then there is something called mortality index. What is that? This is also important. Number of maternal deaths among women with life-threatening conditions. You saw that life-threatening condition. What do you mean by that? Near miss cases plus the deaths, which caused the pathology that caused both of them. So expressed as a percentage. So mortality index means maternal deaths on the numerator now divided by the near miss cases plus the death into 100. So the denominator gives you all the pathology that led to near miss as well as death, but among them, how many died? So it is lower the better. That means you had more pathology, but less deaths. So high means low quality of care. So again, I use the same example. Suppose on the numerator you have 10, but on the denominator you have 100, the index, mortality index will be 10. On the contrary, there were more deaths on top and less, the same number in the bottom, it automatically becomes 25. So that is the mortality index. So let us quickly now look. I have got not much of time. Manipal statistics I will give you. This is 2011 to 12, which was published. You can see Rupa P.S., Shailja Verma, Lavanya Rai, Pratap Kumar, Muralidhar, and Jyoti Shetty. This is published article in Journal of Pregnancy, a high impact journal. You can go and see that. But this is the one which I presented in one of the international conferences, that is RCOG conference London. That's the time I did this. After that, I have not having the statistics right now with me. Maternal Manipal data 2017 is the current. What is there in the bracket is 15 plus 16. As you can see here, we had total deliveries of 3,055 in 2017 alone. 15-16 we had 4,483. Deliveries increased from 137 to 279 per month. In that period, near miss cases were 50, booked were 6, unbooked were 44. As you can see, unbooked are always more for Manipal. In the previous year, 78, 13 out of 65. Maternal deaths were only 7, all from referred cases, none are from Manipal. So there were total. So if I take the ratios, maternal mortality ratio is, I told you simply, the deaths divided by the total number of deliveries. So it is 16.3 per 1,000. That doesn't mean much. But previous year it was 17.3, slightly, definitely better. But maternal mortality ratio, I told you, more number of near miss cases, less number of deaths in the denominator. So it was 7.1. Higher the better, I told you. Anything more than 5 is very good. So 7.1 is very, very good. Earlier year it was 4.1, not so good. Mortality index 7 by 50 plus 7. That index out of both the near miss and mortality cases, how many died? 12.2. Lower the better. The previous year it was 19.5. We lowered it. So this is how in Manipal we know whether we are improving or whether we are deteriorating. So as you can see here, maternal mortality ratio was improved from 4 to 7, which is good. And maternal mortality index reduced from 19.5 to 12.2, which is better. So that's how you will know. What are the causes? Hemorrhage 42%, preeclampsia 8%, 18%, sepsis 28%, and others 12%. And near miss cases, we had atonic, traumatic PPH, placenta, ruptured ectopic, preeclampsia. I'll just run through this. This is not very important. Almost all complications you can see. What are the interventions we did? Hematoma evacuation, laparotomy, salpingectomy, massive transfusion, hemodialysis, tracheostomy, uterine artery embolization, magnesium sulfate infusion, neurological support, every possible support. So the death, preeclampsia 1, 14.3, sepsis was high, 85.7, hemorrhage was not there in the 17, but it was there in the previous years. Others were also there. So preeclampsia, if you have 100 cases, which means that here 1.9% of the times it will be mortality. Sepsis, you have 100 cases, 10 times, 10% of them will be mortality. This will give us an idea. Earlier year, hemorrhage 4.9 and others 7.1. So we thank all these people who helped us in reducing the maternal mortality in Manipal. So it's a team effort. Together we achieve more. Manipal model means every month we have a maternal mortality as well as near miss mortality meetings. We inform the DHO within 24 hours of any event, and then we also get a meeting with DHO and DC every 2 months. So HOD will inform. There is a perfect information system, and flow of information goes from duty medical officer to medical superintendent to district nodal officer to facility-based nodal officer to state nodal officer. This is the given by Karnataka government to us. We fill this every month and send it to DC. And now I show you the actual video. This is the actual video. See, the aeroplanes are coming down. See, that is trying to land on the same runway. This is trying to take off. And that pilot was so intelligent, he just takes off. Aborts landing and takes off. This is the actual video. Thank you very much for your patient listening. I hope you understood everything about near miss, and you will start near miss audit in your hospitals. That's very, very important. Thank you very much. I hope the PGs were also benefited by this.